Hello, everyone, and welcome to another episode of What's Up Wednesday. My name is Carly Burridge, and I'm the founder and owner of Gaining Health. And today we're going to be talking about a recent journal article in the September edition of the Obesity Journal. So that was volume 29. And the title of the article is Metformin for Pediatric Obesity and Insulin Resistance, a retrospective study within an integrated healthcare system. And the primary author was Concepcion J.Q. et al. And in this large retrospective study, they examined the effect of metformin on weight, BMI, BMI Z-score, and cardiometabolic outcomes. And they looked at over 7,000 patients aged 10 to 17 years of age with a BMI at or above the 95th percentile and having evidence of insulin resistance. And they defined this as patients who either had glucose intolerance or impaired glucose tolerance, prediabetes, insulin resistance or metabolic syndrome, acanthosis nigricans, or PCOS. And so they followed these patients for 2 years. And at the end of those 2 years, there were 955 patients for whom they had this BMI data. And they categorized them into 3 groups, either metformin plus intensive lifestyle changes, intensive counseling and lifestyle changes alone, or routine counseling. And what they found was that at 6 months and at 12 months, the participants that had received metformin, or the patients that had received metformin, had significant reductions in weight, BMI, and BMI Z-scores at 6 months and at 12 months. So the average weight reduction at 6 months was 3.5 kilograms and at 12 months was 5.3 kilograms. So fairly significant. And this was compared to both control groups. And there wasn't a huge difference between the intensive lifestyle counseling alone or the routine counseling. And they also found that systolic blood pressure and high density lipoprotein cholesterol were also improved in the metformin group. They did find also, however, that after 24 months, so after the 2 years, they weren't really seeing big weight changes and BMI changes and BMI Z-score differences between the groups. So the authors concluded that metformin with lifestyle changes significantly reduced weight, BMI, and BMI Z-score in pediatric patients with obesity and insulin resistance up to 24 months compared to lifestyle counseling alone. And the fact that these changes were no longer significant at 24 months, the authors suggested that could either mean that maybe metformin may exert a temporary effect that is no longer seen after 24 months, or simply that the compliance with the metformin and or the lifestyle modifications was reduced at 24 months, thus resulting in a loss of that clinical effect. So some of the takeaways from this study is that one, metformin is an affordable, readily available medication for the treatment of obesity and insulin resistance in the pediatric population as well as in the adult population. However, especially in the pediatric population where there's limited pharmacological agents that are available, metformin may be a very helpful tool in the treatment of pediatric obesity and is readily available, it's affordable, so those are all great benefits of metformin as well. And it's generally well tolerated. And I find, especially if you prepare your patients for some of the potential GI side effects and start slow, I like to start with just 500 milligrams extended release and gradually increase the dose as tolerated. Of course, we always know that pharmacological and even surgical tools are always just an adjunct to lifestyle changes. So I certainly want to make sure that we're not just suggesting that we just treat everything with pharmacological treatments alone. This is always an adjunct with the lifestyle changes. However, it's important, especially with pediatric obesity, that we start treating these kids because most children with obesity do not simply just grow out of it and they end up becoming adults with obesity. So it's imperative that we take pediatric obesity seriously and treat it with the evidence-based tools that we have available to us. And just as an aside, some of the other anti-obesity medications approved for the pediatric population include phentermine for ages 16 and up, phendimetrazine for ages 17 and up, and liraglutide 3 milligrams or Saxenda, which is approved for ages 12 and up. So if you want to find out more about pediatric obesity management, I highly recommend the Pediatric Obesity Algorithm, which is available through the Obesity Medicine Association at obesitymedicine.org. And if you are looking for additional resources and tools for your obesity practice, make sure you check out gaininghealth.com. All right, that's all we have for this week. So I look forward to seeing you all back next week for another episode of What's Up Wednesday. Until then, bye.